Hi everyone, welcome to BGCS webinar. We have got the team from the National Ovarian Cancer Audit today joining us to present their data. So we've got Georgia, who's one of the clinical fellows, Andrew's one of the methodologists, and Sudhu and Aggie, who I'm sure you know, who'll be joining for questions afterwards. So just a bit of housekeeping before we start. If anyone's got any questions, if you put them in the question box and we'll run through them at the end. You can use the chat box to make comments, but all questions in the question box, please. After this, you will get a questionnaire sent out, some feedback, and that'll be how you get your certificate, so please do fill that in. And a recording of this webinar will be available online within the next 24 hours or so. So if you know anyone that's not managed to make it, or if you want to listen back, do sign on and have a look at our back catalogue. So without further ado, I will hand over to Georgia and let her talk you through her work.
Great, thank you very much, Katie. Can everybody see my screen?
Yeah, that's good.
Great, amazing. Yeah, thank you for the introduction. It's a great pleasure being here this evening to discuss the National Ovarian Cancer Audit findings. My part of the presentation is around the state of the nation results, and I will also do a live demo of how to access the data viewer. So starting with who we are, the National Ovarian Cancer Audit is one of the 10 national cancer audits being delivered by NatCan, the National Cancer Audit Collaborating Centre. NatCan was established back in October 2022, and the aim is to strengthen the NHS cancer services by looking at treatments and patient outcomes across the country. On the right-hand side, you can see our pictures. And moving on to the background, as you know, there was the Ovarian Cancer Audit Feasibility Pilot that preceded NOCA. That was announced in 2019 and was a jointly funded project. And it was the first project that used routinely collected data in England to evaluate ovarian cancer care. And the first report came out in January 2020, and there are 5 reports published to date. And the feasibility pilot had some really important findings. First of all, there was great variation across the cancer alliances on stage of diagnosis, treatment rates, and also survival outcomes, both 1 and 5 year survival. We also learned some lessons. So the first one was around issues with data completeness. So we kind of realized that specific data items were missing, such as the FIGO stage, performance status, and recording of residual disease. So each one of them had different levels of missingness. We also realized that there were some issues around reporting at the Cancer Alliance level. And an example of that is the West Midlands Cancer Alliance, which has 5 separate cancer centres. And by reporting at the Cancer Alliance level, made it hard for these centres to tease out their individual results. I just wanted to reiterate the healthcare improvement goals that NOCA has. The first one is to increase the proportion of patients receiving timely diagnosis and treatment decisions. The second one is to increase the proportion of patients receiving molecular diagnostics, increase the proportion of patients receiving surgery, increase the proportion of patients receiving chemotherapy, and last but not least, improve rates of survival and reduce variation in survival. So coming to the 2024 State of the Nation report results, for England, we included women diagnosed with ovarian cancer in 2021, and for Wales, we included women diagnosed in 2022. We reported 4 performance indicators. The first one is the emergency admissions 28 days prior to diagnosis. The second one is the receipt of any treatment within 9 months from diagnosis, and that can be surgery and or chemotherapy. The third one is the receipt of platinum-based chemotherapy within 3 months from diagnosis. And the fourth one is the 1-year survival. As I mentioned before, we reported at an integrated gynecological cancer system, which is the units and cancer model that most of you are familiar with. And we found 40 cancer systems in England and 3 systems in Wales. The emergency admissions indicator is also being reported at the trust level. And coming to the actual findings, there were 5,735 women diagnosed with ovarian cancer in England in 2021, and 293 women diagnosed with ovarian cancer in Wales in 2022. In both England and Wales, most women were diagnosed with either stage 3 or 4 disease, and while the mean age at diagnosis was 66.6 years in England and 65.8 years in Wales. And our State of the Nation report includes 5 recommendations that stem from our performance indicators. So our first recommendation is to reduce the current rate of emergency admissions by improving efforts to increase symptom awareness amongst women and primary care professionals, and by reviewing the diagnostic pathways to improve timely testing. And as I said before, our first performance indicator, which is around emergency admissions, showed that approximately 4 in 10 women had an emergency admission 28 days prior to the diagnosis. And that number varied across the cancer systems in England and Wales, ranging from 32% to 55%. Our second recommendation is to review the percentage of women with stage 2 to 4 or unstaged ovarian cancer who received treatment of any type, explore and address some of the reasons behind the variation across the integrated gynecological cancer systems. And that comes from the fact that approximately 3 in 4 women received surgery and or chemotherapy. And again, that number varied across the cancer systems in England and Wales from 62 to 89%. And a really interesting finding is that these results are quite similar to the feasibility pilot one, which showed that 73.7% of women received any type of treatment. Coming to our third recommendation, this is to review the use of platinum-based chemotherapy in women with epithelial ovarian cancer, stage 2 to 4 or unstaged, and explore and address some of the reasons behind the variation across the integrated gynecological cancer systems. And again, that comes from the fact that when we measured our third performance indicator, we saw that approximately 2 in 3 women received platinum-based chemotherapy. And again, this number varied across the cancer systems in England from 51 to 89%. Unfortunately, we were not able to report this indicator for Wales as the data on chemotherapy regimens were not available for Wales. And coming to our fourth recommendation, this is to review 1-year survival in women diagnosed with ovarian cancer, explore and address some of the reasons behind the variation across the integrated gynecological cancer systems. And looking at the 1-year survival, the unadjusted results, we saw that in England, approximately 7 in 10 women survived at least 1 year after the diagnosis. And again, there was some variation across the cancer systems from 54 to 86%. And for Wales, we saw that approximately 3 in 4 women survived at least 1 year after the diagnosis, and across the cancer systems, this number varied between 72 and 76%. And then we proceeded by, we did some, we wanted to present some adjusted results as well. So we adjusted 1 year survival to account for differences in age, ethnicity, deprivation, stage, morphology, grade, charge of comorbidity index, and frailty score. And by doing this adjustment, the 1 year survival varied from 58 to 80% across the English and Welsh cancer systems. And that's illustrated really nicely on the right-hand side, where we have this funnel plot. Each dot represents a cancer system. The straight line is the national average, and the lines, the dashed ones, are the 95 and 99.8 control limits. And moving on to our 5th recommendation, which is to improve the completeness and quality of data items recording in the national cancer data sets. An example of that is to improve the percentage of women with recorded diagnosis based on histology or cytology, and the percentage of women with recorded staging information. And that comes from the fact that 12% of women with ovarian cancer in England and 11% of women in Wales did not have histology or cytology recorded in the National Cancer Registration data. For states, we saw that 28.5% of women in England and 12.3% of women in Wales did not have staging information recorded. And I'm going to finish by showing you how to find our data viewer, because we received lots of feedback about the fact that people find it hard to find our data viewer. So I'm just going to go to Google and just Google National Ovarian Cancer Audit. And you can see our main page. And in order to find our reports in the data viewer, you'll need to go all the way down to the report section. And that opens this window, which has all our reports. So by going to the NOCA State of the Nation Report 2024, you can see the report itself, but also the data tables, data viewer, the methodology supplement, quality improvement action plan template, and our glossary. So I'm just gonna press on the data viewer, and as you can see, there is an Excel file being downloaded. And if you actually open that, don't update now, okay. So you can actually navigate across the tabs, and the dashboard cancer system is where you can find individual provider results. So there's a drop-down menu where you can select the cancer system that you want to check. I'm just gonna go for leads. And then by changing this box, you can select the indicator that you want to check. I'm gonna go for 1 year survival case mix adjusted. And this table here shows how the system performs and what's the ranking among the 43 cancer systems. And that's being illustrated as well on the graph, where the pink line indicates where the system sits among the other cancer systems. So I'm gonna hand over to Andrew now, who's going to talk about our first quarterly clinical performance indicator report. So over to you, Andrew.
Great, thank you, Georgia, and I'll ask for next slide when I want you to move on one slide. So next slide, please. So I'm Andrew Hutchings. I'm one of the methodologists on the audit, and I'm presenting both what I was originally going to present, but also at the end, a section that IPEC, senior methodologist on the audit, was originally going to present, but is unfortunately not able to today. So George has told you about the State of the Nation report and what it covers, what we recommended in it, and that's a report that we will produce once a year. What I'm going to talk about next is our quarterly reports. So in October this year, we released our first quarterly report that included clinical performance indicators. And what I'm going to cover now is briefly how you can find it and what it looks like, and then secondly, how it differs from the State of the Nation report that George has just told you about. Next slide, please, Georgia. So George has shown you how to get to the audit's website, and when you get to that reports page, then instead of going to the State of the Nation report, if you instead go to the quarterly clinical performance indicators tab, then that will take you to the page on the right. And here for our quarterly performance, it gives a little bit of background information, and by clicking on the green highlighted tab that I've circled in red, that will take you to the equivalent spreadsheet dashboard that reports the quarterly report data. Next slide, please, Georgia. So I'm not going to show you how this works because it's very, very similar to the spreadsheet that Georgia has just shown you. So this is just an example screenshot of it showing, I think I picked Guy's, the cancer system led by Guy's and St Thomas's Trust here, and looking at an indicator showing changes over time in this case. But I would encourage you to have a look at the quarterly report dashboard as well as the State of the Nation dashboard. Next slide, please, Georgia. So what is this quarterly report we're doing? Well, it's something which complements the annual State of the Nation report, but the reason we have these quarterly reports is that it allows for more frequent updating of results that we present for both the indicators reporting data quality and also the performance indicators. It's based on more recent data, so it allows us to provide, I mean, it's certainly not real time, but it's more recent than the data used in the State of the Nation report, which are diagnoses in 2021. There's also a difference in focus. So the State of the Nation report is, as it says, it's about the national situation, but there is some information on providers. But the quarterly reports are much more targeted at providers. So one indicator we report at NHS Trust level, the majority we report at the system level, and we also report information at the alliance level. And it's also focused more on how the indicators change over time rather than being a comparison across, for example, the different cancer systems. So the plan is in the longer term that these quarterly reports become a resource that allows trusts, cancer systems, alliances to look at how indicators are changing over time. They may be able to use this as a resource to examine quality improvement, for example, if there have been changes in services or a particular quality improvement initiative has been implemented. And when we put together our first quarterly report on the performance indicators, we're actually able to report on the same 4 indicators, the same 4 performance indicators that Georgia told you about in the State of the Nation report. So emergency admissions, treatment within 9 months, the use of platinum-based chemotherapy, and 1-year survival. In the future, this won't always be the case, so we are planning to include additional indicators in the State of the Nation report for data that we receive on an annual basis, and these won't be included in the quarterly reports because we won't have more recent data to update those indicators on a regular 3-monthly basis. Next slide, please, Georgia. So why are we doing these quarterly reports? Well, this is a little bit of background on how they differ from the annual report. We use different data for the more recent quarterly reports. The annual report is based on gold standard registration data that typically takes at least 2 years for the National Disease Registration Service to turn into the high quality data that it is. For the quarterly reports, we're basing it on rapid cancer registration data received by the audit. Georgia, could you take over for 1 minute whilst I need to get to the door? You'll know why I need to get to the door.
Yes, that's absolutely fine. So as Andrew was saying, we're using different data for the quarterly reports, and these are called rapid cancer registration data. And there are some issues with using this data. So there is some under capture of around 15% compared with the gold standard data. There are also more incomplete data, and an example of that is the methodology.
I can take over again, Georgia, now, so you're free. So many apologies for that. My Christmas tree delivery was any time between 8 o'clock in the morning and 10 o'clock at night, and it just happens to have come now. Sorry, so back to the presentation. So George just mentioned some of the differences. One is that not everyone is included in the rapid data compared with the gold standard data. The data tend to be of less good quality, particularly the most recent data, and examples of this might be lower information on staging, less good morphology. So that's a bit more of a challenge for some of our indicators that depend on morphology, for example. So when we report platinum-based chemotherapy in our indicator, we rely on morphology data to identify who is an ovarian cancer patient with malignant epithelial cancer, and we're less able to accurately do that within the rapid data as we can with the gold standard data. Another caveat is that our quarterly reports are only based on cancer systems in England, because there's no equivalent of the registration data in Wales. So we spent, as an audit, quite a lot of time over the summer working out how good were the rapid registration data for this quarterly reporting. And we reached the conclusion that we wanted to have as specific a cohort as possible. We wanted to minimize the number of ineligible women that we might be including in the reporting. And this led us to restrict our reporting to 1 year further ahead than State of the Nation. So in the October report, we reported on patients diagnosed up to December 2022. In future reports, this will advance to a later date. So every 3 months, we will be pushing that cohort, that date further ahead. So in January's report, we hope to be able to report possibly to June 2023 in terms of diagnosis, but certainly until March 2023. So that will be advancing every time we produce a new quarterly report. Next slide, please, Georgia. So this is the section that IPEC would have presented. I'll be covering that. So we've previously covered the quarterly report and the State of the Nation report, and both of those reports are in Excel format. So when you go to the website, you will get to a spreadsheet that you can download. From January, we're going to be shifting to a new online dashboard format, which we believe will be a much more user-friendly approach to accessing the data. It will be eventually used for all 10 of the NatCan audits, and we're expecting, I believe, 7 or 8 of them to be reporting that way in January. So that's going to be quite a big change in how we report. We want to get a lot more input on this new dashboard that we're going to be producing from patients, from our clinical community, from commissioners as well, in order to improve it. And that's something that NatCan will be doing over the next 6 to 12 months as we get feedback on the dashboard, and we hope to add extra functionality. So some examples of things that we want to add to the dashboard could be things like reporting by particular subgroups of patients. Might be that we report different types of measure. So all our measures are binary measures that, well, we report as percentages, but it could be indicators relating to time to treatment, which would be another way of presenting information. There could be opportunities for presenting different types of visualization. This could include, for example, maps to show how results of our indicators compare across different parts of the country. And longer term, we'd also hope that it would allow for more cross-audit reporting. So rather than focusing just on, for example, a specific audit, trusts and cancer alliances might want to look at how they compare across the 10 different NatCan audits. So we'd very much welcome your thoughts and recommendations on what you think of the new dashboard that we're producing in January. So please get in touch with the audit to let us know what you think about the new format. But in the meantime, currently we just have the Excel spreadsheets presenting the audit's results. One other change that we'll be doing for the January report is that we're adding in a new indicator on 2-year survival. So that will run alongside our 1-year survival indicator. And we would plan for that to also be reported in the same way. So an unadjusted 2-year survival and also a case mix adjusted 2-year survival indicator. So move to the next slide, please. So this summarizes the indicators that we are currently reporting or which we are hoping to develop in the near future. So as an audit, we're expected to report up to 10 performance indicators. And as you can see, we have 8 listed, 3 of which are in development. And we currently don't have access to the data to report on these yet. So those are 3 indicators that are longer term ambitions for us to report. As part of our development of indicators, then we follow basic criteria for establishing indicators, in that firstly they have to be measurable. So indicators need to be defined with available data in a valid, reliable and fair manner that allows any differences or changes in performance to be attributable. Secondly, they need to be actionable so that feedback of that indicator can actually translate into improvements in care. And finally, they need to be improvable so that actions to change the way that, for example, care is provided can have an effect and impact on patient care and potentially patient outcomes as well. So again, we'd be very keen to hear from you about your suggestions for other indicators that the audit could produce. So please contact our team. The email's at the bottom of the slide, so please get in touch if you do have any ideas. Next slide, please, Georgia. So other activities that are going to be happening in the audit over the next 12 months or so. Firstly, we're going to be planning a quality improvement initiative. So that's initiated at the moment. Sudha is a key person involved across NatCan, all 10 audits, in driving that. And that's something which we hope to have in place by September 2025, although the exact date may not be the same. It may be a bit of flexibility in that date. Second thing is we will continue to communicate with all our target audiences through newsletters, through social media. We're considering also adding LinkedIn as a means of communicating. We'll also be continuing to attend conferences, for example, next year's BGCS in July. And then finally, we have a patient and public involvement forum that's met twice so far in the audit, and we have another meeting there in May next year where we're able to take on board the views of women living with ovarian cancer. Next slide, please. So that's all from us on the team. I don't know if Sudha or Aggie have anything they wish to add, but I think we may have some questions that you'll let us know about.
Nicely presented, guys.
Fab. Okay, so unless any from the team have anything got to add, I could run through some of the questions.
So the one thing I wanted to add was it would be really lovely if people were to log on and look at their data, both the state of the nation, which obviously is 2021, but also more importantly for the quarterly reports, and keep looking at it over the year, because our aspiration is to provide a much more recent snapshot, and it's a rolling snapshot. So the aspiration is that if people put in QI efforts now, then in 18 months or 2 years, they can see it changing in the data. And it's for the quarterly reports, it's not necessarily the cross-sectional view, but the trend is more important because the numbers are slightly different from the state of the nation. So that's the point.
If I can also add that we are doing also a number of research projects and try to dig into that data in a bit more detail. So we will be able to update you as time goes on, about the findings. But there are a number of questions that we haven't sort of presented, which are exploratory at the moment.
Perfect. So just to run through some of the questions to open up to the team. So now you've got the data illustrating variation in outcomes, for example, the treatment rates. What are the proposed next steps to understand why the variance is there? For example, is it capacity, staffing, or variation in department's philosophy to treatments?
So this is a killer question, isn't it? I think if people knew the answer, then they would, it would be a much easier thing to do. So there's going to be a quality improvement initiative that's going to be launched next year, and there'll certainly be, we're setting out the principles for across the NatCan audits as I think in the first instance, and there'll certainly be some community pulling together the community in sort of February, March time to try and brainstorm how we can address this. I suspect one of the first QI things we need to do is data completion to try and get because specifically to address the treatment variation thing, we have many key data items that are not fully filled, like performance status or residual disease. It's very hard to unpick that for chemotherapy or surgery if you can't honestly say that these two indicators that are so critical, you have a lot of missingness for. So that's the first step to do. I think the first step is we'll have to pull together the community in sort of March, April-ish time, talk to people to try and understand what underpins this treatment variation. I think a lot of it is underpinned by the variation in diagnostic pathways. The high proportion of people who are being admitted as emergency, and George is doing a lot of work on that. So we have to probably improve the state of play of the person who's walking in through the door, and also improve then the rescue that happens in the hospital. Aggie?
Well, really just the same what you've said. I mean, we are trying to look deeper into that data to see whether, for example, the number of women who don't receive any treatment is linked to poor presentation, poor performance status. We're looking at the SCARF index, which is a sort of an equivalent of electronic frailty index, and also Charson comorbidity index. That might answer some questions, but the quality of data here and reporting is the most important, really, isn't it?
There's been a question saying if we are, if you've got the data and you can show that what the variation is in the population, if you have a centre that's performing well, adjusted for all of those things, is there any plans to look at what those centres are doing, and can we learn and distribute that? Would that be part of as well?
So I think there's definitely a plan to look at the positive outliers, to try and see. I think Professor Jan van der Meulen would caution us to say that positive outliers may be data quirks, and I think it's really important not to oversell it at this point in time. This is why the quarterly reports are quite important, because we need to see consistent thing. But yes, I agree. We need to see what the positive outliers are doing in terms of with all of these things. I suspect my own theory is that it's probably it's a bit like Formula One racing. You shave off a little bit of time for everything that you do, and there isn't one solution. So it's probably addressing how people, and a lot of it, if 40% of your patient population is presenting as an emergency and they are 3 times more likely to die because they have an emergency admission, then there's a lot of a good place to start would be, how are you identifying these patients? How are you making that journey from some jerry ward to receiving chemotherapy quicker? So I think if we started there, we would, I think, be able to learn a lot from people, from what best practices, and then disseminate it. So we are hoping, with Georgia's work and Ray, who's Aggie's PhD student, also working on this to understand this a little bit more logically from a sort of data perspective. And then there's the actual work of talking to people and understanding staffing, which is a whole different ballgame altogether.
And there's another question, which I suppose is the flip side of that. So if you've got a department that appears to be having outcomes that are less than expected, what would be the expectation? Would, like you say, that might be a data quirk? Would they be asked more in-depth assessment or more data?
So there's a process.
Shall I take this one? Yes, in HQIP, the Healthcare Quality Improvement Partnership that funds national audits, has or standard outlier processes for its audits, and audits are expected to follow those. At the moment, the new cancer audits, including the ovarian audit, are not operating an outlier policy because we've only done one State of the Nation report. It's our first go at doing risk adjustment. So we're not operating this, but in the future, either for the next State of the Nation report or certainly the one after it, we will be operating an outlier process that where we do identify an organisation that is outside of the outer control limits, the 99.8% control limit, then we would contact that organisation and follow that standard process. So it will be happening, and it will be following other audits approaches to looking at outlier or potential outliers. I'd say the analysis itself may uncover lots of reasons why it's appearing to be an outlier and actually is nothing of the sort.
The first step is the trusts would be required to look at their data and just check that the data is indeed the way it is, and then they're asked to look at it a little bit more and perhaps do action plans and before the escalation happens.
Okay, perfect. So, or technical question. So if a patient is diagnosed with one cancer treatment centre but moves to another for some or all of the treatment, which centre would she get counted in? Where would she be assigned to?
Georgia.
I'll do this one as well, Sudha. So,
okay.
So Georgia and I did quite a lot of work on service mapping. Some of you may have seen Georgia's poster at the BGCS earlier this year. The way we assign patients to the cancer system is that we first look at the relationships between the units and the centres. So where the trust has a very close relationship with a particular cancer centre, another trust, then we would expect to assign those patients there. That doesn't always work across every NHS trust. So sometimes we do it on a hospital basis rather than the trust basis, for example, where there are legacy mergers, but old referral pathways are still in place. And then for a case where a cancer unit maybe refers a patient for surgery to a cancer centre that's atypical, we would then assign that patient to the system led by the cancer centre that does the surgery. So if anyone's really interested in the detail of the methods, then please have a look at the methodology supplement that runs alongside the State of the Nation report. And that includes a breakdown of the methods we use, but also the trusts and patients that contribute to each of the 43 systems that we report on in State of the Nation.
Okay, so if a patient, for example, was diagnosed in one unit and then chose to seek private care in a completely different centre, would that be captured or?
We don't receive data on private care. So the only data we receive is patients treated in the NHS. So one of the caveats that we report in our analysis is we don't know what happens in the private sector. So if a patient is diagnosed privately, then we wouldn't know necessarily that happened. We would only know when they, for example, first get picked up in the NHS. And so we sometimes miss information at the beginning of that patient's pathway, and also the other way around. If a patient is diagnosed in the NHS or starts having treatment in the NHS, but then moves privately, again, we lose that information. So this would be an example where patients might be diagnosed in the NHS, but if they were treated privately, we would get that indicator wrong about treatment because we wouldn't know that they did actually have their surgery 3 weeks, 5 weeks after being diagnosed. That's a limit of the data that are collected nationally.
But I think the key thing here is that this is not about individual patients. This is about the majority of patients at a given point, place, and time. And so it's, I think, where you have big patient flows, that will have been picked up in the data. If you have the odd patient who decides to come to be diagnosed in Birmingham, but decides to go and be operated on how diabetes, that will not show, basically.
And is there any evidence that patients are using this data to choose where they would want to have their treatment, potentially further away from home?
Not at the moment. I have to say I did anticipate that there would be more patient scrutiny than there has been, quite honestly. There has not been, and you could say it's a good thing or a bad thing, but we certainly haven't been deluged by, we have very good relationships with the cancer charities. We haven't been deluged by patient views. Georgia, would that be fair?
Yes, I agree. Yeah, so far we haven't seen any, any patient like saying that, my cancer system is not performing well on that indicator or the other indicator. I think they all understand that at the end of the day, we want to improve care for all women with ovarian cancer. So yeah, they haven't complained about that so far.
I think experience from previous, so there have been previous national audits in cancer that have been running for a lot longer than NOCA has, and again from those I don't get the impression that it's affecting patients wanting to choose particular places to go. And there's been published research looking at some of the drivers of, for example, where patients do get treatment outside of the usual referral pathways, but I don't think it's a very high number.
So there's a comment come in. So when Kevin Burton, so said, when Scottish QIPs were looked at, we felt that the issue of emergency admission was felt to be slightly outdated. We kind of know those patients will have poor outcomes, so what's the point of looking at them? They said that education and raising awareness in services seeing the emergencies is important, but it's also difficult to achieve penetration.
Sorry, say that again.
So it's just a comment rather than a question. They're saying about the emergency admissions, saying that they feel that it's when they've looked at the Scottish data, it's quite slightly more outdated marker, and they feel that we know those patients have poor outcomes, so why look at it? So they're saying that education and raising awareness in those services seeing emergencies, so GP and A&E, is important, but it's difficult to achieve good penetration.
Okay, so Kevin, thank you for that. That's a really important point. Firstly, I think it is a hard target because it reflects how our outreach to our primary care works. But care in England is devolved into cancer alliances where GPs are completely integrated to that. And as you know, it's integrated care boards that then form the cancer alliance, and cancer alliances have a lot of money to spend across both primary care and the diagnostic pathways in order to facilitate this. I think whilst it may be difficult to move that needle completely, I think ignoring that very big 40% of people who have an emergency presentation would be really difficult. And then we may be at a point where we can't actually change anything subsequent because, if the patient's coming in at death's door, it's very hard to salvage them to give chemotherapy. So then you can't increase your treatment rates. So this is why we thought that whilst it's a complicated and difficult problem to address, we had to put it in and actually look at it. And Georgia's PhD is in fact based on were there any opportunities to investigate this before. And Kevin's pointing out that he doesn't say that the marker is outdated. It was pointing out, which is a very good point, that the attitude of the service receiving the patients is outdated. And this is a battle we face in Birmingham, where palliative care are bloody writing off patients who, anyway, I will start swearing in a minute. You're quite right. I can't agree with you more, Kevin. Yeah. We do need to change the attitude of the people in palliative care, in geriatrics, in acute medicine, because they see disseminated disease and then they start writing patients off. And that I think is something we can do. That is something I think we can do in gynae cancer centers, that we actually can engage with our colleagues across secondary care. We can engage with our colleagues in other specialties. That is upon us to do, to at least give these patients a reasonable fighting chance of being salvaged. I think Katie's frozen. I think so. Yeah.
Yeah, thanks, is frozen.
So the others, Katie, are you back?
Katie, can you hear us?
Oh. So the other thing we sometimes I hear from my colleagues is that, but it's not us. It's not the patients who are in cancer centers. It's the patients who are in the cancer systems. And why should we be concerned with improving outcomes for the cancer system? And I'm afraid, guys, this is a centralized system. It's a gynae cancer hub and spoke model. We signed up to be gynae oncologists. We are responsible. That's it. Which might sound like a harsh gig, but it is.
Fab, sorry, my internet dropped out.
No worries.
I'll have to repeat that again for me when I see you next, Sudha. So there's a comment from Ellie Brockbank saying we can do if we engage across specialties, have an active advanced ovarian cancer service that links in with teams, we can drive that ethos forward. So supporting that. And also from Ellie saying we're seeing women referred to us for surgery that will then go back to the original cancer centre, and presumably they might see a few secondary opinions. Did you say, Georgia, that would get picked up in the data flows if there's quite a large number of second opinions come into centres?
Yes. So the way that we, for the time being, we look at where these patients get surgery. I mean, first of all, is the trust of diagnosis and where this trust belongs. But we attribute patients as to where they got surgery and then chemotherapy. So there is an algorithm of attributing this patient to specific cancer systems. And there is a whole section in our methodology supplement on how we do that.
Would it be helpful if Georgia put a link to her poster? Because then that has a really nice map, your systems mapping poster. Maybe it would be really helpful to send it to Debbie, who can circulate it out to the attendees of to help explain it.
Yeah, I can do that.
All right. Okay, fab. So that is all of the questions. So we bring it to a close there. So thank you everyone for coming to speak today, and thank you for the audience for asking questions.
I'll say one thing, if that's okay. We really hope to pull together the community sometime early next year to start formulating how the QI should work. I mean, there's an ATCAN wide initiative, so it's not something exclusive to ovarian cancer, but I think we can start the conversation around how do we improve things as a community, I think. And the nice thing about us is that I think we're very engaged in gynae, far more than others. Sorry, Aggie.
No. Plus, we do need those extra 2 performance indicators. So it really would be good to hear your suggestions. There are 2 more that we can add to the current performance indicators, and it would be nice if it could come from you.
Fabulous. Okay, thank you. So if everyone can just remember to fill in the feedback form so you get your certificate, and the recording will be available online tomorrow. So thank you again for the team for presenting. It was excellent.
Thank you.
Yeah, thank you for joining us.
Thank you for having us.
Thank you.
Good night.
Thank you.
Good night. Thanks, Katie. Bye.